So for those of you that are just signing on now, we're going to give it a few more minutes and we'll start at 8:05 to give everyone a little bit more time to sign on. All right, good morning, everyone. We might as well get started since those minutes seem to be ticking by us very slowly. So welcome everyone again to our Mount Sinai Health System Elmhurst Neurotrauma Conference at its new date and time. We're going to try and keep it now on Thursdays at 8 a.m. because that seems to be a time when more people can attend. During the talk, where if you have any questions, just either use the chat function or use the raise hand function, and we'll circle back to them. I'll keep track of the questions, and if it's something that seems like it's that we need to kind of discuss right then, I can pipe in and let Dr. Reid know. Otherwise, we'll try and circle back to them at the end. Let me just here. So if you want, I'll give you a few minutes. We are going to set it up so that CME for this is we do have this conference is accredited for 1 CME credit through the Icahn School of Medicine at Mount Sinai. If you want to scan the code here, that'll take you to the cloud website that'll allow you to claim your CME. I'll show it again at the end. If not, remind me, but I will try to remember to put this up again. But we are going to be setting it up so that it has the same, text function that our Grand Rounds has, where you text in and it will record your attendance, and then you'll be able to do the evaluation later. So without further ado, our speaker today is Dr. Patrick Reid. He's an assistant professor of neurosurgery at Mount Sinai and is the new chief of neurosurgery at Mount Sinai Morningside, and is also the director of spinal neurosurgical oncology at the Mount Sinai Health System. His expertise is in the treatment of spine tumors, revision spine surgery, thoracolumbar spine deformity, you name it when it comes to spine surgery. And as part of that, he has extensive experience and training in spine trauma during his residency at the University of Southern California and at LA County, which we were just talking about earlier. He received his MD degree from Rutgers, New Jersey Medical School, and his undergraduate degree at Wesleyan University. So without further ado, I'm going to hand it over to Dr. Reid, who's going to be talking about the surgical management of thoracolumbar fractures. Let me stop sharing there. And
thanks very much for that introduction. How is the slides look okay? You guys can see this?
we're seeing your presenter mode for now.
Ah, geez.
I think if you flip it, there's a button that you can just switch it from one to the other. Yeah, perfect.
So again, thanks for the introduction. Go into my personal history a little bit more because I think it does inform this talk a fair amount. I certainly appreciate it. And I think, like Zach touched on, feel free to fire any questions into the chat. More like a call and response thing, and it is perhaps less functional in this context, but I think we can still it's somewhat conversational and hopefully explore this topic, which is actually, I think more interesting than initially presents as. We're doing here. My disclosures, I work as a consultant occasionally for Medtronic and for therapeutics, neither of which is particularly relevant to this talk. So this is a sort of a repurposed or updated version of my LA County Chief talk, which is probably the time in my life when I was really, I guess, in a groove with regard to this disease. So just touching again more on my personal history, because it is somewhat relevant to this conversation. I did my residency or the first med school in the first few years of my residency at Rutgers. And then finished my training at LA County. In the middle of my training, though, before I finished, I spent a year at HSS doing a lot of deformity and degenerative surgery with those guys. That was PGY6, then went back to LA for my PGY7 year, armed with all of these, I guess, fancy principles that I'd learned during my enfolded fellowship. And then went up to the University of California, San Francisco, where I did another deformity fellowship with an emphasis on adult deformity and some tumors. And then went back across the country again. I've been at Columbia for the last 4 years, and then I just recently started here a couple months ago, which is, I guess, kind of all informative because when you look for the literature in this topic, it's a little bit sparse, certainly when compared with other aspects of spine surgery or even neurosurgery. And there's reasons for that, and we can get into them. But ultimately, what happens is this talk ends up being just kind of, my opinion. And it happens pretty fast, given the paucity of literature. So when you get my opinion, I guess just keep in mind everything, grain of salt. It's informed by my training more than anything else. And while I did have a lot of trauma in residency, when I talk about it now, it's probably informed an awful lot by my personal history in deformity surgery and tumor surgery, which is mostly what I've been doing for the last 5 years. But I guess to get started on the topic at hand, thoracic and lumbar trauma is very common. Level 1 trauma centers think the number of something like 7% of blunt trauma patients present with a thoracic or a lumbar fracture. Overall, close to 40% of them are from car accidents or motorcycle accidents. And about 30% of them in falls. In Los Angeles in particular, those numbers are a bit skewed because there's not that many tall buildings in LA because of earthquakes, but they are able to drive their cars and motorcycles pretty fast. So there's probably more MVCs than there are falls. Like I didn't see a jumper's fracture in my time at LA County, but then coming back to New York, you start seeing them more often. Just certainly proportionally, falls are probably a greater proportion of what we see here, given that people have a hard time getting their cars up to, trauma type speeds, or at least as commonly as they did in LA. Right. So then just our personal experience, for instance, in 2014, and this is pretty indicative of what people have reported across the literature. You see about 150 of these fractures over the course of the year in 2014. 65% of them were just compression fractures, 30% of them burst, and then 5% mix of fracture, dislocation, and chance fractures. And again, in keeping with the majority of the literature, about 20% of these end up being surgical, right? Which makes sense because you're going to end up operating on pretty much all the fracture dislocations and about half of the burst fractures, and ideally none of the compression fractures, broadly speaking. So we ended up doing, about one of these surgeries a week at LA County, which is a pretty high rate. I'm not sure if the Elmhurst numbers are similar, but you certainly get a lot of experience. Talk about separation, that tends to be the best thing, again, given the paucity of the literature. So this talk is going to have 3 parts. I'm going to spend the first part talking about the classification systems that are out there, essentially the history of classification systems, because I think that's pretty interesting, given the influence that they have on our decision making. And the second part of the talk will address this is surgical management, essentially what we did over the course of that year and how I tend to approach these patients, which can be either very straightforward or somewhat complex, like anybody else. And then lastly, again, given the lack of literature in this topic, some opportunities that I see moving forward to try and advance the field a bit. So just to start with classification systems, broadly speaking, they're interesting in that they are typically driven by a few different things. If you go back far enough, or I should say more recently, morphology informs a lot of these. That is like what the bones actually look like when they're fractured. Just as commonly, in fact, more commonly as you go backwards, or if you end up in Europe, mechanism greatly informs our classification systems and the way we talk about this disease. In fact, a lot of the morphology is informed by the mechanism, right? A compression fracture, we think of, you think of a shape of a compression fracture, but it's also defined by its mechanism. Compression is a mechanism, right? But and then the third thing that'll start to encroach more recently in these classification systems is neurological status, which to us seems very important and very intuitive, but actually didn't really come into play until more recently. But ultimately, when we start talking about the decision making to operate or not to operate on these patients, stability is very important. And a lot of times, particularly in the classification systems that put all of their emphasis on the bones and the bony structure, stability is really what we're trying to predict based on what we see in front of us. At the time of the patient encounter, is this patient going to be stable, right? And that can mean a lot of things. It's not necessarily always binary, right? Sometimes things are sort of stable, but especially in the trauma sense, it's probably when it's most binary. You need to figure out if somebody needs an operation to stabilize their fracture or if they don't. And then the operation that they may need for a decompression also informs that decision. So going back historically, looking at the development of all these classification systems, the first one that I was able to find is from the 20s, the 1920s. It's from Germany, like a lot of them are. And it is essentially defined completely by mechanism, right? It coined the term compression fracture, which has really hung in there over the years. And it is entirely descriptive, but something that was important as a landmark, essentially. It's getting things going. And you get to about 10 years later, and we're still using compression fractures, in this instance called a wedge fracture. But Dr. Watson and Jones started talking about stability and trying to make some predictions about whether or not these fractures were stable. And the general thing at the time, ultimately correct, broadly speaking, is that compression fractures are stable and fracture dislocations are not, right? It's somewhat intuitive and easy to predict that if your spine blows up, it's not going to hold up very well. But the sort of gray areas, what we think of as burst fractures and things like that, we really had a hard time defining over the years. But these guys started making a go of it. 10 years later, there's another version of this time taking into account, some coronal alignment, different sorts of fractures. Dr. Nickel was the first one to start talking about the interspinous ligaments, which is a big step and certainly something that's remained important, although it's undergone, at least in the way we think about it, a number of evolutions. And then, so getting into the 50s, especially in LA, I always talk about how important this guy was. Usually ask some intern if they know who he is. Hopefully the right technology for that, but it's Dwight Eisenhower. He's important because in the 50s and 60s, we started building highways in this country, and the evolution of cars and seatbelts really led to a significant increase in this, the prevalence of this disease. And it is, if you look back 100 years, it's important to keep in mind sort of the context in which we're dealing with this issue, right? Dr. Holdsworth came up with this system's 5 different mechanisms. Was it 6 different morphologies? The first one to start talking about the 2 columns, essentially the columns of the spine, which is another thing that we still learn in med school, though it's been a little bit updated. And he also talks about the posterior ligamentous complex, his own way. Seat belts, these 2 guys. This is the slide that I would put in when I was a resident to try and get Dr. Weiss or some other more senior neurosurgeon to start taking over for me if I needed a short break, because they would start talking about Dr. Hounsfeld and John Lennon and how they're related, essentially. But essentially, it all comes down to the CAT scan. In the 1970s is when we started getting more advanced imaging, what we think of as advanced imaging. Keep in mind, everything up until this point has just been rotenography or X-rays. So a lot of the morphologies, or at least that would inform why the morphologies are less important or subordinate to mechanism, because there's an awful lot of, if you only have an X-ray, there's an awful lot of information in a mechanism. And once you start having CAT scans, it becomes less relevant. It's more important what the bones look like at the time. Another thing to keep in mind is in the 70s is when we started coming up with pedicle screws. So if you start talking about treating these fractures before 1970 at the earliest, right? But really probably more like in the 90s, you're talking about Harrington rods and hook constructs that are less robust in terms of their fixation. And then if you go back even further than that, you're essentially talking about casts, look like hammocks and bolsters, and then in figure 3B here where you're hanging people by their feet. Certainly not the kind of treatments we have available to us today, but it is, I think, important to know about because it certainly informs the terminology and a lot of the culture and the dogma that's been carried over. In the 80s is when we get to the things that we still kind of learn today. Like in medical school, you still learn the Denis 3-column model. It's easy to learn. It involves morphology, which I tend to think of as more informative than mechanism. And this was really the first one of these systems that started taking into account neurologic compromise, or at least trying to predict it, right? The middle column disruption was associated with neurologic compromise. It led to more surgeries, and essentially what you learn in medical school is if the middle column is disrupted, then that person needs a surgery. It gets a lot more complicated than that, and like I said, the correlation of the classification with neurologic deficits actually drove really the usefulness of this classification system, certainly when compared with the ones from the past. That in combination with more advanced imaging and treatment modalities probably made treating this disease more common than it had been, or certainly more successful than it had been. Unfortunately, the papers that define this classification system diminish the posterior ligamentous complex. I think it only has a modest role when compared to the middle column, which perhaps not correct. But otherwise, this is a pretty useful classification system, certainly for 40 years ago. In 1994, the Germans got back into it. Oh, and in between, they invented MRIs, right? So it's important to keep in mind now in the 90s, MRIs are starting to become more prevalent, and it is possible to visualize on imaging the posterior ligamentous complex, right? In the past, they were diagnosing disruption by palpation or just observation, right? So if the spinous processes are clearly splayed, then that means the posterior ligamentous complex has been disrupted, which is a fairly specific way of diagnosing that issue, but not particularly sensitive, which is easy to imagine. But the Germans come up with this system. It's got 3 different broad categories, again, defined almost entirely by mechanism. And then they immediately start dividing those categories. And this system sort of becomes fractal in its complexity, just increasingly comprehensive, but ultimately somewhat unusable. And certainly better defined, more precise than the Denis model. In 2005, essentially a consortium of surgeons just kind of came up with this classification system. And while not, terribly scientific in how they came up with it, it's probably, to my mind, the most useful in a day-to-day. It has three elements: the morphology of the fracture, the neurologic status of the patient, and the integrity of the posterior ligamentous complex. Essentially, you sum those, and if you get to the right score, then the person needs surgery. Less than 3, no surgery. Over 5, definitely surgery. And if the score is exactly 4, you kind of get to do what you want. And so they did a retrospective evaluation of this system in Sao Paulo, which I thought was actually pretty interesting. So they looked at essentially 1,300 patients over the course of 10 years. And over that time, they'd operated on 460 of them, roughly, which comes to about 35%. So pretty aggressive in terms of their management. They may be operating on some people who don't necessarily need surgery, right? And of those, about 9 out of 300, so 3% of people failed conservative management and ended up needing more surgery later. Helix score of 3 or less, and 16% of them had some interesting complications. So certainly when we're talking about the sensitivity and the specificity or the predictive power of a model, the Helix was pretty good. And looking back, they noticed that this cohort of surgeons, well, it's probably somewhat indicative of global practices, or at least practices in the United States as well. We're operating on a lot of Helix 2 burst fractures. So specifically burst fractures without neurologic deficit or disruption of the posterior ligamentous complex, which, strictly speaking, if you're following the protocol, don't get surgery. There were some interesting complications and probably validated the Helix decision-making algorithm pretty well. They then did a prospective study in the same cohort of patients. Ended up operating this time on 65 patients over 3 years, right? So that's much fewer patients than they were operating on, or about half the number. 37 patients with fractures treated conservatively, 28 surgically, and the complication rate somewhat similar. And only 2 patients treated conservatively in that group ended up needing surgery later. One of them just for axial pain, and one of them for both kyphosis and pain. Unfortunately, neither of them improved their pain. And both were involved in work-related litigation, which is unfortunate. Helix, to my mind, somewhat overreaches when it comes to trying to define the approach needed for surgery. It does, probably favor the anterior column in a way that's a holdover of the days of Harrington rods, when you really needed to augment your posterior fixation with more anterior column support. Probably less relevant with robust pedicle screw constructs, but overall, this is a very good classification system, and kind of splits the difference in between the Denis and AO models in terms of precision and usability. And then in 2013, AO, recognizing the weaknesses of their classification system, in terms of pragmatic use, tried to simplify it, and so this is the friendly graphic that tries to make the AO spine classification system more approachable. And I've almost learned this at times, but then unfortunately they do try and add in some neurologic injury things and some modifiers and an algorithm, and the next thing you know, you're talking about a T9A3N3M2 fracture, and it is less usable. at least in terms of your clinical day-to-day practice. So just broadly speaking, again, 3 different versions of modern, you could say, classification systems. The Denis model, very simple, very easy to use, not terribly accurate. The TLIC system, sort of splitting the difference in terms of usability and precision. And then the AO model, probably too precise, a little too complicated to use in your day-to-day, but certainly if you wanted to use it for research and precisely define as many of these fractures as possible, it's probably the best classification system to use. So that's more or less where we are in terms of like how we started classifying these fractures and making decisions about how to manage them. The surgical management of this disease is like the surgical management of any other spine disease. We talk about the things that we're able to do in spine surgery, and this will be repeated, in just about any disease model or any talk. Things that we can do include decompression, realignment, and stabilization. Right, that's what we can do. In terms of decompression, the important questions are: does this patient need to be decompressed? Right, driven almost always by their presence or absence of a neurologic deficit or the severity of their neurologic deficit. And then should we do it now? You do it immediately? Should we do it urgently? Or should we do it whenever we can? And oftentimes the timing is going to be determined exclusively by the neurologic status, and although somewhat informed by the comorbidities, right? So typically speaking, if someone has an incomplete injury, certainly to their spinal cord and nerve injuries below, typically L1 tend to be less urgent. But if someone has an incomplete spinal cord, Asia A, Asia B, Asia C, you typically want to do that surgery as soon as you can. Something like a complete Asia A injury, where someone has neither motor nor sensory function below the level of the injury, those typically do still need surgery. The thinking to decompress these patients sooner rather than later is certainly becoming more prevalent, but I don't think anyone thinks that this is quite as urgent. The rates of recovery in a complete spinal cord injury are still relatively low. They are probably improved by early decompression, but given that the benefit is smaller or lower than it is in an incomplete spinal cord injury, the amount of risk that you're willing to take on to do it is probably less. And then an intact patient, you more or less have as long as you want, given if you're able to move that patient around without further destabilizing them, then you probably, you do it in the safest way you can. So the way that I typically think about it is: an incomplete injury, you take as soon as you can; a complete spinal cord injury, you take when you're able to; and an intact patient, you take as soon as it's safe. All right, so almost 3 different levels of urgency with these patients. And, ideally, if someone's unstable, you do them as soon as possible. So what informs whether or not you're going to take somebody who's intact to surgery tomorrow is informed by their comorbidities, right? And so polytrauma is pretty common in this patient population. And so it involves a lot of conversations about risk and benefit across specialties. It's important to maintain open dialogues with other services and try and get a sense, certainly when someone has a disease in their cardiopulmonary system, TBI, going with our brain colleagues. Oftentimes we're making those decisions ourselves, or any other life-threatening sort of injury. You want to make sure everyone's on the same page in terms of how safe is this and how urgent is this, and how can we balance those concerns. Another thing that we're able to do is realign patients, right? So frequently, particularly in the higher energy fractures, we're going to need to correct some deformity. If you're actually going to correct it, you need to have some idea of what the spine is supposed to look like. Natural state, and that is different depending on what part of the spine you're in, right? Thoracic, the thoracic spine is shaped differently than the thoracolumbar spine, which is shaped differently than the lumbar spine. And it's important to keep the ideal alignment in mind, and also keep in mind that it changes from patient to patient when putting in a construct that's going to stabilize but also lock the spine in place, right? And then stabilization concerns, again, anterior versus posterior and the length of your stabilization. There are interesting decisions. The sort of boilerplate posterior operation that we did at LA County and that I do today is two up and two down from the fracture level. But we'll get into that talking about some specific cases. So just going segment by segment, the thoracolumbar part of the spine, so that's T10 to L2. It's certainly the most common area in Los Angeles, at least in terms of injury. It is a straight part of the spine. And it's also important to keep in mind the neurologic structures that you're dealing with. As I said, they do change as you go superior and inferior throughout the spinal column. What you're typically dealing with in this part of the body is the cauda equina, right? So not quite nerve roots, not quite spinal cord, but something that you can't exactly move around ad lib. So just a few examples of what we were dealing with in Los Angeles. At one point, we had this 62-year-old man who was in a seatbelted car accident. He was out in his lower extremities, but his sensation was intact. Essentially, an L1 Asia B. Ended up taking him for surgery, very quickly. This is the boilerplate construct that we used. Again, 2 up, 2 down. He ended up getting a T11 to L3 posterior spinal fusion, a nice straight rod, and a well decompressed spinal column. I'd follow up in 1 month post-op. He's 4 out of 5, right? So these incomplete injuries tend to do very well. Thoracolumbar fractures are pretty straightforward to fix. Getting an anterior decompression can be technically challenging, especially in the trauma context where you don't necessarily have the most virginal of operative sites. Fractures and disrupted tissues tend to bleed a lot. So you don't always necessarily want to do a corpectomy. We were able to get pretty good decompressions in Los Angeles, and by taking down, doing it like a medial pedicle removal, just going through the pedicle, much like we do in tumor surgery, and tamping forward the burst part of the bone. And while you can see on the sagittal image to the right here that it's not perfect, it's almost always good enough, and probably the better choice between going around and doing a full corpectomy and losing another 800 cc, and then you got to deal with all the sequela of that, right? Here's a little bit of a more interesting case. That one was pretty boilerplate. This is a 61-year-old man who was assaulted, we think, who presented with a right-sided L2 radiculopathy from this L2. Well, I think it was initially categorized as a compression fracture. If you look on the coronal images to the right, even in the middle there's a obvious coronal deformity, and looking at the facet joints there, you can see that this patient's spine is a fracture dislocation, right? And I think initially the surgeons responsible tried to do a 1 up, 1 down operation, which can certainly work in some contexts, but in this one, it did not, right? So you can see this is 3 weeks follow-up on his x-rays. The coronal deformity is worsening. There's a kyphotic deformity is worsening, and those screws are exiting the spine, fortunately. Here it is delineated on the CT. And also subsequent imaging demonstrated an L4 pars fracture. So ultimately, this patient ended up getting a really long construct, which is unfortunate. But we were able to correct his deformity, maintain his alignment reasonably well, and stabilize him across the fracture. Looking at my old x-rays always kind of gives me agita, but this one looks okay for a PGY7 doing that operation. This is, I think, an interesting case. A 34-year-old female pedestrian struck, presented with an aortic dissection, left lower extremity fracture, but intact. And certainly looking at this CAT scan, it is very hard to tell that there's anything wrong here. But certainly the mechanism of injury is not without any benefit to analyze. When you have a high energy injury, you have to be even more careful and as discerning as possible, and squint at a lot of CAT scans, at a lot of cuts. As you can see up in the thoracolumbar spine, there is this area that just kind of doesn't look like the others, right? The disc space is a bit wider, maybe some splaying here posteriorly. The spinous processes, and even though the joints are relatively lined up, you can see something funny is going on here. So in cases like these, you kind of have to jump up and down to make sure you get an MRI. The MRI will oftentimes demonstrate, one, this disc is totally disrupted, the posterior ligamentous complex is totally disrupted, and frankly, you just look at these two images, the spine's moved. So this young woman's spine, her thoracic spine, is moving, if not independently, perhaps more than you might like, regard to her lower body. And without an MRI, it's kind of challenging to diagnose this as a fracture dislocation. But with, it's pretty straightforward, right? She ended up getting a surgery and doing reasonably well, right? So those are thoracolumbar injuries, thoracic injuries. Again, that's T1 to T9. This is the kyphotic part of the spine, particularly from T6 to T9 or T5 to T9. You need to keep that in mind if you're going to be trying to reconstruct anything. Thoracic injuries almost always are high energy injuries, right? These are your motorcycle crashes, really high speed car wrecks, which makes sense. I mean, this part of the spine is stabilized by the rib cage. A lot of times they'll be accompanied by sternal fractures. That's always a concerning comorbidity. And it's also a spinal cord level. So, if we're talking about T1 to T9 injuries, those are certainly the most anxiety producing and probably hardest to deal with comorbidities that you typically see. So motorcycle crash in a 28-year-old, not an uncommon story. T3 Asia A and a T1-2 fracture dislocation. These are challenging cases. You end up having to go into the cervical spine to account for some lordosis. It's also very hard to get imaging, especially in more robust people. This is a post-op x-ray that we got, and you can see our C7 screw. It's okay, but it is suboptimal. We just weren't able to image it properly in the operating room at the time. The guy's shoulders were so thick. So we were able to get otherwise pretty good fixation, pretty good realignment. He never improved. We're able to get him reasonably stabilized. It's just important to keep in mind these cases are challenging, right? Here's a similar case, essentially 54-year-old man in a high-speed car wreck. He's got the sternal fracture, he's got TBI, he's got a T3-4 fracture dislocation. Ended up having surgery for that. No, this is a more challenging case also in the thoracic spine. A T4-5 fracture dislocation. Certainly when you see gaps like that in the spinal column, it is alarming. This is an unfortunate woman, pedestrian struck with a TBI, who was intubated and had an aortic dissection, but seemed otherwise to be doing well. I remember visiting her in the morning after she came in, and she was moving her legs. The problem is it started to seem like she was moving her legs a little less well than she had been, and certainly asymmetrically. She didn't have any other competing orthopedic injuries, but she was intubated. She wasn't necessarily following commands very well. It put us in a really tough spot, given the obviously unstable nature of her spinal cord, of her spinal column, and the questionable nature of ongoing injury. So we ended up operating on her, trying to just stabilize her and decompress her across that fracture dislocation. And our post-op films for her, unfortunately, it's just this chest x-ray. This is because she decompensated in the operating room. I mean, we'd spoken with all the other services. She made us very nervous, but she just went in the tank, in the middle of our operation. We had to whip stitch everything closed. She ended up getting the full trauma workup, but she ultimately died. And even with an autopsy, we weren't able to figure out what happened. So it's certainly important to do everything you can to figure out, one, what's the nature of these neurologic injuries, and two, what's the nature of the comorbidities, trying to determine the timing of this operation. But even, when you do what we thought was our best, we probably should not have operated on this. So occasionally these cases are not as straightforward as you might hope. Lastly, the lumbar spine. These fractures are more rare. The lumbar spine will bend and not break. in a way that the thoracic spine is not able to. It is lordotic, and you're dealing with nerve roots at this level, not the spinal cord, not the cauda equina. So you have a lot more leeway in terms of moving the neural elements around, which is nice. So L4 and L5, particularly rare, given the flexibility at those levels and the forces that they're subjective to, at least in Los Angeles. Like I said, we didn't see very many axial loading jumping fractures. I'm not sure how common you guys see these fractures at Elmhurst. Certainly interested to find out, but we didn't see this very much. But when we did, one thing we needed to keep in mind is that, you know, if somebody has a fracture across L4 or L5, for the most part, you're going to end up fusing into the pelvis. And if you do that, you got to keep in mind the patient's pelvic incidence and be certain not to flat back them, right? Which is something that we can see pretty commonly if you don't take things like this into account. The problem is you don't get all your deformity imaging. It's not like we have an EOS X-ray of the entire body every time somebody comes in through the emergency room in this context. But what you do have typically is a chest, abdomen, pelvis. And one of the things that we did in Los Angeles, just, you know, as a quick abstract or quick paper, was just, you know, demonstrate that you can figure out pelvic incidence from a CT. And you should, if you're going to be fusing people, using someone from L3 to the pelvis, L4 to the pelvis. If you're going to be fusing across 4-5 or 5-1, you got to look at their hips. L3, I always think of as a bit of a special case, right? As it is, you know, it's accessible laterally, which is nice. But if you start talking about doing the typical 2 up, 2 down, like an L1 to L5 operation, given the forces on it with a long lever arm and the fact that there's only one disc in between the lumbar spine and the pelvis in that context, you start worrying a lot about that disc breaking down, particularly in this population, which tends to be young. The likelihood of that person ultimately needing to be fused to their pelvis, either in the long term or, you know, more concerningly the short, is pretty high, which is again more of an intuitive thing and not necessarily been demonstrated in the literature for reasons we'll touch on later. But L3 is just, it's vexing. But like I said, it is accessible laterally, which is nice. The psoas muscle is small. It's below the rib cage. It's above the iliac crest. So you can get to it from the side. So what we started doing, or what I did a couple of in Los Angeles, is these lateral approaches for a corpectomy, right? And so what you're able to do is come in from the side and get a pretty reasonable cage in. In this case, we had to fuse a little bit higher than we wanted because of some ligamentous disruption, but it does allow you to stop your construct short of L5. So in this case, it stops at L4. Giving the patient 2 discs below the level of the injury. This was the second case that I did like that. Is you know, L3 burst fracture. This guy's intact, although you can see quite a bit of compromise of the spinal canal. And so this is the second one that I did. I thought I did a much better job getting in a nice big construct and just going 1 up, 1 down and decompressing the canal very well from the side. It's a nice operation. The only issue being that these L3 fractures are so uncommon, they can be hard to get good at. And I stopped doing lateral surgery for the most part 5 years ago. So there aren't that many indications for it. A lot of people do a lot of it. If you're handy with it, this is a nice surgery for just this case. And it's kind of the one time where you will hear me advocating for anterior column operation in the context of traumatic injuries, right? All right, so some research opportunities just to finish up. What we were doing in Los Angeles is just, you know, research is hard here. Or in this patient population, they tend not to follow up, right? They are very heterogeneous, and for the most part, unless you're at a major trauma center, there aren't that many of them, right? So we were operating on 1 a week, seeing about 150 a year of these fractures. So we were able to get some things started, but it's very labor intensive, and keeping track of these patients is famously difficult. So one of the things we were able to do with the two people I was working with at the time, is Phil Bonney on the left. They're here, shown here in our hospital command center. Always looking out the window pensively in the command center. This is when he was an intern. And then Arthi Patel, who's now, I believe, a PGY3 at UCSF. Phil will be going, he's a chief at LA County now. He's going to UCSF also to do his trauma fellowship next year. But with their help, we were able to essentially categorize and gather as much data as we could on a lot of these patients. And you know, LA County was switching EMRs at the time. We had to do a lot of chart review. It was labor intensive. I think we didn't have Epic. I think we just gotten Cerner there. But we were able to make some progress, put out some interesting things that I thought. The problem is the follow-up for these patients is not great, right? You're talking about 4 months, 7 months, nobody more than 13 months of follow-up, pretty much as a rule, which limits what you can do. In spine surgery, you like to see about 2 years of follow-up before you can say whether or not you did a good job. So you're very much limited unless things change follow-up wise a great deal in the coming years. So what you can kind of figure out at the time of surgery, or essentially before the patient leaves the hospital. And to do that, this is certainly informed by all the different places that I've traveled all over, is steal from other practices in spine surgery, and specifically deformity surgery, looking at alignment, right? Even in these short segment fusions, and as is sort of addressed earlier, you want to make sure that the spine's lined up correctly, and this is the sort of thing you can assess with imaging before the patient leaves the hospital. We did a few abstracts on this before I left LA County, but the tricky part about that is you kind of got to leave. So we weren't able to get amass the number of patients and the sort of imaging that we wanted. So certainly, like the practice of getting X-rays post-operatively, not super common at LA County before we were there. I think it's well instituted now. They're probably have more robust numbers on that front, but certainly something that's interesting to look at. Another thing is the predictive analytics. With the advent of the EMR, we have a lot more information available to us than we used to, and deformity spine surgery in particular has really been taking advantage of defining both the invasiveness of the operation that we're doing, trying to algorithmatize our operations, and also the frailty of the patient, right? So trying to assign the patient a number that describes how sick they are. And certainly there's a fair amount of variability in these trauma patients, the polytrauma patients versus the isolated fractures. That is, well, not easy to define, certainly the sort of thing you can take a run at. But ultimately, I like this slide because it demonstrates the two main elements of trying to pursue these research avenues. One is that it's going to be Epic. I think this is the email that I got when Columbia switched to Epic, and the EMR is valuable research standpoint because of the volume of information that is captured. Now, it still takes a fair amount of work to wrangle that, much data, but it certainly makes it possible, and it's the sort of thing that we're developing practices for and getting better at. But then I also like the picture of this because it sort of demonstrates that you need a team. No one has the sort of volume to get up to the numbers where you can say something interesting or necessarily very true about this patient population. It is ultimately a political exercise to try and get everybody on the same page and gather patients and communicate effectively and try and design protocols that work for everyone, and hopefully get us up to the numbers needed to power the studies to say something interesting about the patients. And that's part of the reason that this conference and those like it are so valuable. I think we can end on that note. Certainly questions. Interested to hear.
Yeah, if anybody has any questions, just raise your hand and I can elevate you to give you the ability to speak, so to speak. So I'm actually going to put up the QR code. I know I did post the QR code in the chat for CME, but I'll put it here as well. That was an excellent talk. Thank you, Patrick. Very good overview of everything. I did have at Elmhurst, you asked about a couple things. At Elmhurst, we definitely see, I think, less thoracolumbar injuries. I mean, maybe, L1, Yes, and some T12 from as you mentioned from falls in particular. So we still get like the axial loading injuries, but we definitely see a lot less of the fracture dislocations, and the more kind of classic, chance fractures, MVA type injuries
Yeah.
that you could see. We get a lot of cervical. I think cervical is probably our most common, at least operative injuries. We have a lot of more elderly patients, so we get a lot of central cord patients, and then we got a fair number of patients that have, dish or have a spondylitic spine that then, have like 3-column injuries related to, falls. And a lot of odontoid fractures too, actually, but in elderly
Right.
patients. Yeah, less young patients, odontoid fractures. So like, I think I've done one odontoid screw the entire time I've been here because they just, the number of young patients that actually
Yeah.
indications for an odontoid screw is pretty rare here. All of the
Everybody does one.
90% of our odontoid fractures are,
Yeah.
65 plus old, so it's first the decision whether or not to operate or not at all
Yeah.
in those patients. And then, usually we're coming from the back, in those patients, but yeah.
Yeah, certainly, cervical trauma is a whole different topic. I wouldn't say that the literature is a lot more informative, right? It's just very challenging, as I'm sure, you've noticed over the course of the last few years, to study these patients, get them to come back and see how they're doing, which is unfortunate, but it certainly, in turn presents some opportunities to try and figure out what's going on with these people and say something interesting about them as best we can, at least until we're able to build the machines that essentially track them down, right?
Yeah.
Which is kind of what you need to do with most of these trauma patients. But it is interesting, just the diversity of injuries, almost the ecosystems that present these fractures, right? Like in LA, it's just all cars going fast. It's just a lot of young men falling off their motorcycles. Certainly around here, and it's actually probably interesting to look at looking at our trauma numbers here, just the electric scooters are changing the presentation of these patients, given that those have obviously sort of increased in prevalence, at least certainly anecdotally, but I think it's pretty clear around New York City, and how it's changed the type of injuries that we're seeing from institution to institution.
I think both Dr. Margettis and Dr. Capinos have questions. So Dr. Margettis, do you want to go first?
Great presentation, Dr. Reid. Thank you. A quick question for burst fracture without a neurological deficit. What kind of criteria do you use to guide you between surgery and non-operative treatment? Do you use like the degree of comminution, the degree of focal kyphosis?
It's almost entirely, for me, with a few exceptions, right, driven by the integrity of the posterior ligaments complex. So, or at least from a trauma perspective, right? Like, okay, from a stability perspective, if this person's PLC, specifically the ligamentum flavum, if that looks okay, then they're probably stable. You can find out you're wrong, but you will at a very low rate over the course of the next few weeks and months, and usually not in a way that is going to, compromise someone's neurologic status or do something irreversible. So strictly speaking, the ligamentum flavum is the most important thing. Yeah, if somebody has like 45 degrees of kyphosis across a level of the thoracolumbar spine, I'm going to think hard about correcting their deformity, especially in a young person. If they don't have a ton of other comorbidities, things like that, all the sort of normal considerations you need to make, then I'm going to think about doing it. But then that's a deformity operation, right? That's not a trauma operation. I'm less worried about their stability than I'm about their quality of life. And you certainly have to consider that kyphotic issues tend to get worse. Strictly from a stability standpoint, which is most of the time what we're talking about in this setting, it's the ligamentum flavum that kind of makes it.
Yeah, I mean, I would say that the ones where they've still had the posterior ligamentous complex intact, where then I still needed to, and they're neurologically intact. I don't need to operate from a neurological perspective. Where I've had them worsen over time is particularly the osteoporotic patient, that has a relatively comminuted fracture, and then over the next few weeks or month or so that their anterior column fails, and then, but like you said, then it's really kind of a deformity surgery. And even at the initial time, I've gotten burned both ways, where I had done a corpectomy up front and then they failed and I needed to do one. And then also when I've done a corpectomy up front and then they subsided with the cage because, because they're osteoporotic to begin with. And, it's very hard to prevent subsidence, obviously.
That's why even in this patient population, it's important to find a way to define their frailty, right? Because grandma's not going to do great no matter what you do, right? And like a 28-year-old is probably going to do fine no matter what you do, honestly. Like sometimes they're frankly unstable and they need to be stabilized and they're going to do great. But like a 94-year-old with osteoporotic kyphotic burst fracture with an intact PLC, like you're in a jam. Trying to think about, what's the least worst thing to do to this person. Sometimes it's surgery. I mean, there's other adjuncts like, vertebroplasty augmentation of screws, but then, you kind of you're always trading one set of complications for another potential set of complications. So it's probably a lot of opportunity given the diversity of this population to try and define that. Like I said, I'm certainly an advocate for stealing from the tumor and deformity literature to sort of pump out some interesting thoughts in a little bit of a different context with this patient population. But it is obviously something you got to take into account. It's kind of ill-defined.
Dr. Capinos, if you're on, do you want to kind of
react? I was wondering if you could comment, Dr. Reid, on your view, probably not in the lumbar, but in the thoracic area, since it's the case, at least at this cervical level. What is your view on using multimodal modality to guide the management? Like, are we still doing like map augmentation for everybody to just perfuse the cord, or is it really too esoteric, those papers about using cord perfusion pressure as well as even like oxygen or LPR with a tiny microdialysis catheter in the cord?
I think most of the institutions that I've worked at are not really ready to find everything that precisely, right? Especially in this context, if you're in the ER in Newark, New Jersey, or LA County, it's hard to find a nurse that's going to help you reset a dialysis catheter or judge the pressure in the CSF in like a minute-to-minute basis. Certainly for me, the most informative literature, goes back like Mark Hadley and his cord perfusion, essentially avoiding, hypotension, right? Particularly in the upper thoracic or cervical spinal cord, where people are certainly at risk for spinal shock. A lot of times you'll find yourself in the ER and you're kind of the only one that knows that the fact that this patient's systolic blood pressure is 85 is really bad for them, right? Especially in the context of an incomplete spinal cord injury. And even just getting, the systolics up, get maps, the literature says over 85, but honestly, it's just like, get it up. 5 is probably not necessarily better than 75. It is a lot better than 60. And unfortunately, probably right now, that's in most institutions, at least, that see a lot of this disease. Best we can do. If you start talking about the logistics of trying to measure these things, it's very challenging. So in my experience, that's probably the most important thing. And even that, we're having a hard time getting the penetrance that we need where it's needed. But yeah, I mean, those things are fascinating. It's just very hard to institute. I'm sure Zach can speak to this too, like the more elegant monitoring modalities in trauma settings.
Yeah, Dr. Okonkwo gave a good talk at our virtual neurotrauma symposium that we do with the New York Neurotrauma Consortium every year. Gave it a couple of years ago about, in Pittsburgh, they're starting to place lumbar drains in all of their spinal cord injury patients and measuring, and it's certainly not standard. It seems like there may be some utility there, but we haven't started doing it here, partly because it's kind of like at the end of a long case, and you're just like, do I want to stick it now? Do I want to spend another, half an hour at the end, position them doing a lumbar drain for something that, is still not necessarily standard, but, maybe at some point it will be, it seems like, we were also involved in, a spine scaffold implantation trial. It was a phase 2 trial, but basically, one of the thoughts was like, well, is the whole surgery for the scaffold, is the benefit that we potentially see from that actually just related to opening the dura in these patients, and having a dural decompression as in addition to, the bony decompression.
Yeah, I mean, certainly I think that's the main challenge facing is even at a place like UPMC, which is, big trauma center and, what you think of as like a almost gentleman's league, like research institution, it's really hard to generate the numbers in heterogeneity or heterogeneous population that you can actually power a study that's going to discern the difference between, a spinal cord perfusion pressure of versus 50, right? So it becomes such a political exercise to try and get everybody together, so that like your 5 patients that would qualify for it and my 3 patients can then get lumped in with Daniel's like 15, and then you can maybe start to generate the numbers. But trying to do any kind of study like that it's not prohibitive, but it is extremely challenging to start talking about the heterogeneity of this population and the number of institutions you need to put together to power anything that says something interesting and correct.
A good example, I mean, like as you mentioned, that phase 2 trial that I mentioned, I think we had more sites involved in the study than we had patients, right? Because of how difficult it is to find patients to enroll in those, particularly when you're going for a very homogeneous type of population in your study, so they had like 20 something patients enrolled and there was like 30 sites involved. So
I mean, you look at the hemicraniectomy studies and the trouble that they had, enrolling patients for like one problem and probably pretty basic operation, and even then, like the population is very hard to study.
Okay. All right, we'll take this one last question from Dr. Lagone, and then we'll finish with that.
Are you sure we're a little over? I can always delay it.
No, it's okay. We got a couple minutes.
I actually had 2 questions, but I'll mark it down, make it one, kind of on what you've been talking about. I think as we all know, the literature around hypotension, kind of what you've been talking about, but hypotension and traumatic brain injury is pretty clear, and it's both continuous as far as blood pressure and dichotomous, below 90, above 90, about the outcomes. I wonder if there's anything in traumatic spinal injury that, rather than not even looking at perfusion pressure, but just really kind of grossly looking at their systolic blood pressure, that helps map it out. Like, is there a level where we see a marked difference as far as the outcome?
I mean, it's tricky because we're essentially trying to study a continuous variable, right? And studying it in a binary way is, easier to do, but probably less accurate. I mean, the number that they picked, I think, was 85 in the literature, and they more or less tried to stratify outcomes by looking at the patient's perfusion pressure, or MAP, in this context, and 85 was a number, and so because of the ease of communication when talking to emergency room doctors, you don't want to be like, oh well, in some cases it's 90, and in other cases it's 65, and so you just say 85. And that's usually going to be good enough. But the important thing, honestly, is just to avoid hypotension, right? And occasionally there'll be competing interests from a medical standpoint why you wouldn't want to drive somebody's blood pressure, right? In this context, maybe not everybody does great with hypertension. But if you can, you just kind of do it. And if somebody's MAP is 82 and it's going to take something dangerous to get grandma up to 88 in terms of a MAP, then you have like a risk benefit conversation about it, and frankly 82 is probably fine, right, for the benefit that we can expect to see in 99% of these patients. But so it's like anything else. For ease of communication, we say MAP of 85. If there's a reason why that's difficult or dangerous, then 85 is probably not the number for everybody, and 75 is probably fine. It just can't be 50.
The data, even though it ended up being a guideline, the data that it was based on is pretty weak. It's like pretty low quality evidence data, and it was, as you mentioned, the marginal benefit from it wasn't huge. Certainly early surgical decompression is probably, for an incomplete spinal cord injury, the single biggest factor in terms of, if they have ongoing compression, how they're going to do. And then the MAP augmentation is, if you can do it safely, do it. But as you mentioned, just avoiding hypotension is probably the most important thing.
Yeah. I mean, if you talk to Mark Hadley about how he came up with that study, he's just like, yeah, we just picked a number.
If you look back at some of the old TBI, it's all kind of, it's not such great literature. I think the newer stuff is actually much, much better and clearly shows a continuum of, you get the 90 versus 100, 110, you're better off. But I didn't know if there was anything and it sounds like not as robust, but same kind of ideas.
Yeah.
Yeah.
Okay.
All right. Excellent. Thank you, Dr. Reid. Thank you, everybody, for attending. Again, scan your QR code for your CME. And I think we are going to probably try to do our next one in early December, so after Thanksgiving, but before the holidays. And so we will let you know about that as we get closer. All right.
Thanks so much.
Thanks, everyone.